From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello, and welcome to our listeners around the world. You're listening to JAMA Internal Medicine Author Interviews. Thank you for joining us. I'm Dr. Ilana Richman, an assistant editor and web editor at JAMA Internal Medicine. And I'm joined today by Dr. Connor Prosty, an internal medicine resident at McGill University, and by Dr. Catherine Mezzacappa, a hepatologist and gastroenterologist and an instructor in the Division of Digestive Diseases at the Yale School of Medicine. Welcome to you both.
Thank you.
Thank you.
In this week's issue of JAMA Internal Medicine, we feature a systematic review and meta-analysis by Dr. Prosty and colleagues that evaluated the effectiveness of prophylactic antibiotics among patients with cirrhosis who present with upper GI bleeding. Findings from the meta-analysis reopen questions about our current practice. And I'm also joined by Dr. Mezzacappa, who wrote an accompanying commentary on the paper. To begin with, I'll turn to Connor and ask what motivated this study. Current guidelines support using prophylactic antibiotics among patients who have cirrhosis and upper GI bleeding. And I think for many folks that felt like settled practice. So what led you to ask this question?
Exactly. So that's been a longstanding sort of grade A recommendation across multiple international guidelines for a couple decades now due to a purported mortality benefit. However, more recent trials in the last few years, two of which demonstrated non-inferiority of shorter versus longer antibiotics, prophylaxis, and one, the largest study now done in these patients in Variceal bleeds, demonstrated that there was no mortality benefit with prophylactic antibiotics. And our group likes to look at strong guideline recommendations and take a look back at what the evidence is underlying these recommendations. And now there's been many developments since that recommendation was first put in place in terms of cirrhosis and upper gastrointestinal bleed care, like IV octreotide, intravenous proton pump inhibitors, banding over sclerotherapy, rescue tips, and restrictive transfusion targets, as well as paracenteses for all patients presenting with ascites to hospital. And so with these sort of temporal changes and these new studies emerging, we thought to ask in 2025, is this still needed? And antibiotics are not benign, and these patients often have a lot of antibiotic exposure and risk for colonization with multi-drug resistant organisms and adverse events from the antibiotics. Even in the brief time that antibiotics were recommended as prophylaxis in these patients, initially it was the fluoroquinolones. Now third-generation cephalosporins are mostly recommended because of resistance to the fluoroquinolones. And so we thought to look back at the evidence and revisit this question.
Great. So there's been some, it sounds like, temporal change in what we've learned from trials and also clear evidence over time of harm from antibiotics, mostly in the way of antibiotic resistance. So tell us what you found. Like, what were the top line findings from the meta-analysis?
So we found that there was a 97% probability of non-inferiority for all-cause mortality for shorter versus longer antibiotics, prophylaxis. And this was even more pronounced when we looked at studies after 2004, after sort of the recommendation for rescue tips. As well, we looked at rebleed, which did not meet our non-inferiority margin, but was also not significantly better with prophylaxis. When we looked at infection, though, infection was clearly higher with shorter or no durations of antibiotics. But there were a lot of quality concerns surrounding this, and there were a lot of quality concerns surrounding all the studies included. They were graded as low to moderate quality. For the infections in particular, the studies, one, did not perform paracenteses in all patients with ascites presenting to hospital, which is now the recommendation. And so we could have ended up missing cases of spontaneous bacterial peritonitis, and the antibiotics in this case would have actually been treatment for it and not prophylaxis. As well, there were routine urine analyses, urine cultures, routine sputum cultures, and chest x-rays performed in these patients as screening for infection. But in the absence of a compatible clinical syndrome, these don't distinguish colonization from infection. And so it's thought that these studies are at risk for overdiagnosing infection. This 15% increase in infection also didn't translate to a mortality benefit. So either these infections weren't true or these were more nuisance infections and not associated with mortality.
So it sounds like the way that those trials measured infection left open the question about whether the infections that were captured in the endpoint were really clinically significant or not. And of course, the groups that received antibiotics may have fewer documented infections, but unclear whether those were important to patient outcomes.
Exactly.
Tell me a little bit about what uncertainties your meta-analysis revealed. Where do you think the data are least clear and where sort of future questions lie?
So I think our meta-analysis demonstrates the non-inferiority of shorter durations over longer durations and demonstrate that it's more pronounced in modern studies. The evidence behind antibiotic prophylaxis in these patients is very poor with the low to moderate quality studies and doesn't currently support a mortality benefit. And we think future trials should address, one, whether prophylaxis is needed at all in 2025 with a well-designed randomized controlled trial with well-defined infection outcomes and adequately excluding infection prior to study entry. And then we also don't really have a good understanding of if antibiotics work, why do they work? Is it the infection causes the bleed causes the infection, or is it sort of translocation from endoscopic procedures? And so, if antibiotics are needed, how best to give them? Should we give longer durations, shorter durations, or just peri-procedural around the endoscopic timing?
Thanks so much. Catherine, I'm going to turn to you for your perspective as a practicing hepatologist. In your commentary, you describe how the care of patients with cirrhosis has changed in recent decades, how we're better able to prevent and manage complications of cirrhosis like GI bleeding. How should we think about the role of antibiotics in the modern era?
Thanks. Yeah, there's been a lot of changes. In addition to the concerns about the specific trial designs that were included in the meta-analysis, a majority of them were from over 20 years ago. So they were done in a very different era of cirrhosis care, where overall we witnessed much higher mortality from all complications of cirrhosis, including gastrointestinal bleeding. And so since that time, in the intervening decades, there have been major advances in our understanding of how to treat the cause of especially variceal hemorrhage in terms of short-term vasoactive agents that decrease portal pressures to prevent rebleeding from varices, in terms of endoscopic techniques, including banding, as opposed to just trying to compress the vessels from rebleeding with external pressure from a balloon. And then, as Connor already mentioned, we have made major advances in the field of interventional radiology to protect patients who are at very high risk of rebleeding by using a TIPS to emergently decrease the portal pressures. So a lot has changed in the context of care in cirrhosis and in gastrointestinal bleeding in cirrhosis. And the use of antibiotics in these trials of antibiotics to prevent rebleeding in patients with cirrhosis and upper gastrointestinal hemorrhage, most of them were conducted in this period prior to all these other interventions. And so both from the perspective of what they were measuring, because their primary endpoint was rebleeding and not mortality, and so they had very short durations of follow-up, but the context in which they were measuring it, it's very hard to apply those to the modern era, where more and more patients are surviving the initial bleeding event and at risk of other causes of all-cause mortality after that event.
So it sounds like because the field has changed quite a lot and because we have more powerful interventions, the relative importance of prophylactic antibiotics for everybody may be diminished over time.
It may be. And I think it's important to highlight that it's the universality of it that's probably inappropriate. Connor already mentioned some of the more recent trials. So a few of the trials were in the more recent years, and one of them was limited to patients who have compensated cirrhosis. So a really, really important distinction and improvement in our understanding of cirrhosis and cirrhosis care is the distinction between patients who have advanced scarring of the liver, so they have cirrhosis, but are compensated, meaning they have not experienced variceal hemorrhage, they have not developed ascites, which is the most common decompensating event, and they do not have hepatic encephalopathy. And in the one trial that looked at just those patients, they really didn't find any benefit to administering antibiotics. And it sort of makes sense, right? If this is your first decompensating event, presuming that the person presented with a variceal hemorrhage, and there is no ascites, preventing spontaneous bacterial peritonitis by administering prophylactic antibiotics doesn't make a lot of sense as a treatment plan. But in a decompensated patient, a patient who has existing ascites, maybe has had bleeding in the past, they are at much higher risk of developing further complications at the time of a gastrointestinal bleed, including infection, because we know that in those patients, all sorts of complications from infection to developing severe acute kidney injury to infection driving rebleeding are much more likely. So it's a distinction between who really needs antibiotics and is likely to benefit from it and who is least likely to benefit from antibiotics. And we think that the best way to answer this, as Connor already mentioned, would be to do carefully designed trials and to do those first in the patients where we have the greatest evidence that it is safe and we have true equipoise around not administering these broad spectrum antibiotics. And those are patients who have compensated cirrhosis.
My last question I'll pose to both of you, and that's a reflection on the notion of the relationship between evidence and practice. In the hierarchy of evidence, we consider meta-analysis to be at the apex. Of course, meta-analysis is only as good as the studies that inform it. Where do you think we are in terms of our practice? Do we have enough evidence to suggest that practice ought to change, or are we in the place where we have a strong case that we need more and better and more contemporary studies? Connor, maybe I'll turn to you.
I would say the latter. I think we're in a place where we need better studies. I think it's hard to say that to omit a therapy in these patients that for so long is believed to improve mortality, I think might be a bit of a stretch. And I think, to convince the general internist and gastroenterologist, I think we need further studies to, as you said, to define who really needs antibiotics, who doesn't, and how best to give them.
Catherine, how about you?
I agree. I think it would be very hard to institute a practice change when this has become a part of what is seen as high quality care in a patient with cirrhosis presenting with gastrointestinal bleeding. So, as I said before, a number of interventions have improved rebleeding and mortality rates in these patients. And it's hard to disentangle the benefit of antibiotics from the other interventions that were added during the same period. And so to independently evaluate the effect of antibiotics, we have to do a trial where that's the only difference between the two groups in the era of modern care. And I think that, just on an individual practitioner level, when something is universally recommended as standard of practice, it's very hard to be the person who is not using it and to make that judgment call about which patient should receive and should not receive a standard of care treatment. So I think we need the evidence to support the change in practice.
Thank you both. Thank you, Connor and Catherine, for this really interesting conversation. I feel like I've learned a lot about the role of antibiotics in upper GI bleeding in patients with cirrhosis. And I think we've outlined areas that are important for future study, both in terms of risks and benefits of antibiotic use. I'm Dr. Ilana Richman, and I've been speaking with Dr. Connor Prosty and Dr. Catherine Mezzacappa about antibiotic prophylaxis for patients with cirrhosis and upper GI bleeding. You can find all the papers we discussed and more in the show notes and on jamainternalmedicine.com. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.